Our diets have changed, and we've also intermarried. Our sense of beauty has changed. As facial plastic surgeons, we're cultural influencers. The language we use is very important with our patients. So ethnicity is a generalized term, but within ethnicity, there are subcategories. To be Asian doesn't mean you're Korean or Japanese. It's such a broad term.
You're creating this other of everybody else, which is pretty much the rest of the world. And you're making the Caucasian nose the standard, which is not applicable to the majority of people. Being able to have the conversation with people and have a comfortable conversation of who they are and what they want it to look like, and using our skills to get to that endpoint with them.
I'm gonna kick back when you face like that.
Welcome to Beauty Unveiled. I'm Dr. Angela Sturm, and this is where we reveal the truth behind plastic surgery, the people doing it, the people getting it, and the people around us. And today I am very excited to have Dr. Jose Barrera. He is a very accomplished facial plastic surgeon and does so many different things and has such an interesting story of getting where he's at. He speaks all over the country. He does research. He's in Miami today. With a new device, so excited to jump in and learn more about you, because I know you, but I want to learn more things. So.
And I'd love to learn more about you. You do an amazing job, and I followed your career from its infancy, and you're truly spectacular. So thank you for having me, Angela. I really appreciate it.
Well, thanks. No, absolutely. So I felt like your story is so interesting because you immigrated here. I actually found out on your website you were in a car accident, and so is that what led you into facial plastics, or like how did you get here, facial plastics?
Yeah, I guess at a young age I was involved in a really bad car wreck, and I was a lifeguard in Rhode Island, and I was going back home to Providence, and I got into a bad accident on the highway, and certainly had some facial trauma. And it's very interesting because as an immigrant coming to the U.S., nobody in my family was went into medicine, was a physician, and so the journey really started when I went into the Air Force, and I had a good friend, still a great friend, Anthony Mitchell, and he's an ER critical care guy, and he wanted to go to med school. And I just wanted to do research, for the Air Force or some crazy special operations field. And it just wasn't working out as well because of, my relationship with my wife. She was my fiance at the time. I said, I can't put her through that. So research was it for me until Anthony turned me on to, hey, you could just apply to med school. And so I with his spurring, I did, and I was able to get in and go to University of Colorado, and we stayed in Colorado for residency as well in ENT, otolaryngology, and so it was great. Just not anything I predicted. Something that I loved. There was another classmate, a friend of mine who was going into otolaryngology when I was a freshman. He was a senior in med school, and he said, it's a great field. You could do plastics, you could do cancer, you could do ears, you could do lots of different things, see kids, see adults, and I thought, man, that's for me. I like doing lots of different things and taking care of all kinds of problems, and I love kids and taking care of adults. So yeah, it worked out. Applied to residency at Colorado, and I think I was the wild card because at the time I was not a typical candidate, but I did do research in med school and residency, and genomics, and spurred me on to be a decent enough candidate to get into residency. And then after that, it was back to the Air Force. I went to Japan. My bride Dina, we just she had gone through med school with me, and residency 9 years, and was open enough to go to Tokyo for 3 years.
Yeah.
And so I disappeared and went to Tokyo, at Yokota Air Base, and I became a flight doc. I flew airplanes, not flown, but I was myself, but I was part of the flying squadron.
Yeah.
And I flew along with the C-130s and the 21s and
That's
was
exciting.
attached to a helicopter squadron and went to Korea. We traveled all over Asia. I even went to Iwo Jima
Yeah.
um, for the Japanese-American Peace Accords. I mean, it was
Oh,
amazing,
wow.
but it was not anything like, what we see, like, where we just put our head down, just to the grindstone and get through fellowship. I actually took a break for 3 years,
Yeah.
and it was the best I could have done because it really opened up my heart to put in more training years after that. And that's what I did.
So what all did you see on the planes and the helicopter? Was it like trauma or like, so you've seen all kinds of
Yeah.
things.
Yeah, I eventually did deploy to Afghanistan, and I did do a bunch of medical missions, both civilian and military, to Chile and Haiti and Rwanda, and I've been deployed to Afghanistan and lots of different places.
Yeah.
But as a flight surgeon, you just take care of the squadron. So if the squadron has a mission, they need a flight doc to take care of the squadron.
Yeah.
Pilots are not trusting people. They are not, because a doctor will pull their flying status if they're sick. And so they need a trust. So the military figured out that to embed a doc with the squadron was the safest way to keep pilots healthy, because they would not otherwise go to the clinic. So
Right.
that's what they had.
It
I
would be like,
embedded
I'm fine, I'm good.
yeah, I became one of the crew, right? Wore
Right.
the flight suit, flew the mission, but it's mostly for accessibility. But that was, I did that for 3 years before my 2 fellowships. So
Yeah.
it was just great to be a doc on my own,
Yeah.
practicing the craft, right?
Yeah. That's really exciting. That's very cool.
Yeah.
So was it the plan to do the 2 fellowships?
I wanted to do facial plastic surgery after residency. I also like neurotology, weird.
Yeah.
But weird that I would think that it was so different, not because neurotologists are weird, but
Well, both are very
or facial,
delicate,
facial plastic surgery are weird. But that was my thing, right?
Yeah.
We are a little weird in our specialty, but yeah, we're very sort of delicate, very refined, and that's sort of what I want to do. And so, yeah, I wanted to further train, and the Air Force wanted a craniofacial surgeon to do trauma, to do maxillofacial,
Yeah.
to do orthodontic, to do plastics. So after my 3 years in Tokyo, reached out to Dick Good, who's passed away now, but he was an amazing, amazing surgeon, amazing person. And Dick said, yeah, we got a place for you at Stanford. Why don't you come?
Awesome.
You could do 1 to 2 years with Nelson Powell and Bob Riley, who were at the time world-renowned orthodontic maxillofacial sleep surgeons. Still are, and they live in infamy. Nelson has since passed away. Bob is retired. I did 2 years with them, but I also did a year with Dick and Sam Most. And it was Sam's first year as a fellowship director.
Oh,
He
really?
was passing on from Dick.
Yeah.
And Sam and I are kind of akin, almost brothers. We're very close in age, but I learned a ton from him.
Yeah.
And I got to, again, be very hands-on at Stanford doing orthodontic work. And so I did that while I also did a fellowship with Sam. So it was great. It was really good. And then I returned back to the Air Force after that.
Yeah. And so is that what brought you to San Antonio? Was the Air Force? Yeah.
Yeah, they had a place. They said, "You're
Yeah.
ours now, boy."
It's a great place.
said,
It's a
"Yes,
great
sir."
city. Oh.
It is a great city.
So I prepped you a little bit. So I've talked to a lot of people about like jaw surgery and that our jaws have changed over time and they feel like we're doing too much to the nose and it's because the jaw is small and that's why we're having to do all these different surgeries. How do you feel about that theory of like the evolution of people, I guess?
Yeah, I mean, I think, yeah, so our diets have changed, and we've also intermarried. Our sense of beauty has changed. We, we see future mates in an idealized world. And so whereas the features that once were very common, full third molars, full mandibular growth, are things that we actually don't look for as much, right? We, I think as a society, our anthropometric, there's a word for you, beauty has changed.
Yes.
And so with that, we've we've become much more similar, and the world is no longer a separate place. I mean, listen, I practiced in Tokyo for 3 years. That's a very isolated people group, and they're an amazing culture. But to be not Japanese, to be gaijin, and you're a foreigner, right? And in America, we have a melting pot of everybody, and our sense of beauty is actually much established in our European backgrounds. Even Nelson Powell, who I trained with, wrote the book on facial aesthetics. And so all the horizontal thirds and vertical fits, that's all based upon Powell and Humphrey's book on facial analysis. And so that textbook was, if you ask Nelson, was purely based upon the European ideal.
Right.
And so wide noses, flat noses, phenotypes that we see in race are not what is taught in traditional training in plastic surgery, and also not what's idealized in our morphing, in our software, in our simulations, on the internet, on AI now.
Right.
It's, so, yeah, I think we've changed anthropometrically, and in a sense diluted our diversity.
Yeah.
If you ask me. Yeah.
Yeah.
I could get on this, by the way. Diversity is something I speak on for rhinoplasty, and I do think that as plastic surgeons, facial plastic surgeons, we're cultural influencers, and so what we see as what we use for our norms will derive a lot from what culture says, but it's a two-way street, and the language we use is very important with our patients. So
I
could be another
agree.
conversation.
I agree completely. And I'm with you. I could talk about it too. What do you think, and this has been sort of a conversation on the sidelines, I think. So when we talk about rhinoplasty and we're putting different terms with it, like how do you feel about the terms that we're using? Do you feel like we should use, because, you'll say ethnic rhinoplasty, and that's such a, I don't know, I guess I have an issue with the term, kind of, like how do you feel about that, and how do you feel like we should talk about it in a more conscious way?
Yeah, no, I agree. I think ethnic is a generality. There's a great article that came out. The Ohio State University came out, and I wrote a commentary on this. I'm bringing inclusivity to the term ethnic rhinoplasty. I actually had an anthropometric medical specialist in my office for a few years ago, and I learned a lot from her. And the idea that ethnicity is something that is a generalized term, but within ethnicity there are subcategories, and so to be Asian doesn't mean you're Korean or Japanese or
Right.
From India. It's such a broad term, and so we group rhinoplasty as ethnic or Caucasian.
Right.
So we can say non-Caucasian rhinoplasty, or the rhinoplasty that we usually think of. And in so doing, we may be suspect to the otherization of an
Right.
entire majority of the world.
Exactly.
It's rhinoplasty for Caucasians, and then there's other rhinoplasty, and we're sort of suspect ourselves to categorization bias.
I agree. You're like you said, you're creating this other of everybody else, which is pretty much the rest of the world, and you're making the Caucasian
Yeah.
nose the standard, which is not, not applicable to the majority of people. And I feel like you're, like you said, there's huge differences between doing all these different noses and what people want and what they want it to look like. And so I feel like we should be a little bit more descriptive in what we're exactly doing rather than, oh, it's not a white nose, you know. It should be,
Yeah, yeah.
you know, and you look for people, and it's hard for patients because they're looking for people like, do you do noses that look like mine, you know, and how can we make that easier for them to find those people?
Yeah. Yeah, and so we're left with this term ethnic rhinoplasty, but in a sense we do a disservice. So on my gallery, I do use, I have like 7 different types of rhinoplasties, and I have do put ethnic rhinoplasty in as a category, but I include like different ethnic races,
Yeah.
so that people can sort of see. And within that category, I have several patients of African descent, but you know, someone who's East African descent versus West African descent is a completely different.
Right.
And so, but I have a separate category for like ethnic rhinoplasty or Asian rhinoplasty. But within Asian rhinoplasty, there's a huge categorization, you know, different Asian rhinoplasties. And having lived and practiced as a facial plastic surgeon in overseas in Tokyo, right, in Japan, and then also having like this melting pot of military patients dependent in a major city, I kind of seen lots of different all over, you know, I've practiced in Africa, I've practiced in, you know, I've seen patients in England, I've seen patients in Chile, Mexico, Dominican Republic, Haiti, you know, Tokyo. I mean, so I've sort of been in almost every major continent doing plastic surgery. I didn't get to Antarctica, but I did get down to Patagonia. I did do surgery in Patagonia, Chile.
Yeah.
Close.
Yeah,
No
you're
Eskimos,
close.
so.
We'll give it to you. That's close.
All right, sounds good. But you know, so I never practiced in Greenland, but you know, it sounds like fun.
Yeah.
But you know, you sort of get this idea of the world a little bit. Certainly not the expert, but I get a better sense of how to start the conversation.
Yeah. And I feel like that's a lot of it, being able to have the conversation with people and have a comfortable conversation of who they are and what they want it to look like, and, you know, using our skills to get to that endpoint with them.
That's right. That's right.
Yeah. And your perspective, I think, is so interesting of like how our jaws have changed over time, because I've talked to people and they're like, oh, it's because we eat different food. But to your point, it's much more complicated than that. Like, I think the genetic selection
Yeah.
makes a lot more sense than, oh, our food has changed. And like, well, I mean, I guess, but no, it makes.
I mean, yeah, I mean, I think chewing, mastication, right, yields a lot of masticatory facial musculature, right? We see people with huge masseters and things like that, but that's like a hypertrophy.
Yeah.
That doesn't mean, you know, I think the facial muscles are derived from the skeletal structures that they attach to, and I think, you know, we intermarry, right? And so
Right.
we have a very diverse group of people, you know, in the U.S. now, and which is great. It's wonderful.
Yeah.
But I remember seeing a study where they took like the average population, like the anthropometrics of like Australia, you know, because they're very diverse with a lot of Asians and indigenous people, and then also a lot of colonial influences from Europe, right? And so the AI program merged the Australian face, and they look sort of like Mexican Asians.
Right.
One face. It's like it could be Asian, it could be like Hispanic Asian, right? But it was like there's no Hispanic or, you know, there's Asians obviously, but it's sort of like this melting pot of all the faces.
Interesting.
So I thought that was interesting.
Yeah, and that's where they ended up. That's pretty interesting.
Yeah.
And we were talking about rhinoplasty, and you're one of the leaders and speak everywhere on preservation rhinoplasty, and I find it fascinating. I still need to come watch you operate, because I
It
do
is
it
so
different.
cool.
Yeah. So what got you started with that? Why did you decide you wanted to do that? Like, explain what that is for people that don't know what that means.
Yeah, yeah. I would credit lots of people. Sam Most being one of them. Back in fellowship, we did this crazy paper, and now it's like completely standard of care for the nasal tip, and that was Ehler, cephalic Ehler, turnover or turn-in flaps, and that's a preservation technique, right? You're preserving the cartilage and utilizing it as a either flip down, turn in, slide under, or turn over to support the lateral crew. I did that in a patient last night. And we wrote that paper back in 2008, 2009, with Craig Murakami's inspiration. So that was like pre-preservation hitting the US. Now there are people like Dr. Fausto Ulloa down in Mexico City, his father taught him, right? He's doing it for 30 years, right? And he did the coddle method. So I credit Sam for getting me involved in cartilage preservation. And then I credit really all the authors and speakers in the US that spurred us on, Sam, Dean Toriumi, into getting into bony techniques in 2020. So then I started doing it. And so I read Sam's paper on modified subdorsal strip, read Carlos Neves' paper on tetras, and decided to go to the cadaver lab.
Yeah.
Same thing I'm doing tomorrow.
Right.
Going to the cadaver lab and trying out new techniques. And I had the advantage of being in the military, active duty, being in a teaching program, that we had human specimen labs available to us every single day.
Wow.
So,
Yeah.
we had our own lab, our own micro lab. And and we would teach an orbital dissection course annually. Been doing that for over 20 years. No, I'm sorry. Since 2008. So not 20 years, but 18. Going on 18. And so I try things out in the human specimen first.
Yeah.
And that's what I do in research. I try it on a human specimen, then I go. So I did my first one on a human specimen in 2020. And then I started doing it for all my patients. And not because it was so dissimilar from what I was doing, because I was already doing orthognathic surgery. I was already doing Lafort cuts. I was already doing mastoid cuts. I was already doing septal letdowns with my Laforts, right? I was already doing that stuff for years.
Yeah.
By that time, 12 years already doing that kind of work. And so for me to get a saw in my hand was second nature.
Yeah.
And of course, in otolaryngology, facial plastic surgery, we do all kinds of septoplasties and extracorporeal septoplasty. So doing septal strips was not that foreign. And then doing the bony cunts was not that foreign. And I was already doing some alar cartilage preservation. So that wasn't so foreign. So I think that putting it all together, and so I went through 100 patients in 2 years, and did a paper comparing mid-strip approaches to like rotational approaches like the Z-flap, which Dr. Kovacevic in Germany has popularized, and then the mid-strip approaches like what Dr. Most and Dr. Neves talk about. And so when I looked at my patient-related outcome measures, my proms, I looked at 45 proms over a year, and 200 patients, and I was like, you know what? There's no difference in the septal strip approaches. The proms were equivalent or better than my structural Joseph component reduction patients. And so I started doing it for the majority of my patients. So I'm 80% preservation.
Who do you do structural on at this point?
I do a structured tip on everybody. Even my functional patients, I do an endonasal e-seg. I published a paper on that, the e-seg, I call it the endonasal seg. So I do a structural tip on everyone.
Yeah.
It's very rare patient I'll just do it has to be like a teenager for me just do a septoplasty.
Yeah.
You know what I mean? Like
Yeah.
somebody who's still growing. We talked about someone who's still growing. But yeah, I'm a structural tip person all the way. But I incorporate endonasal techniques as well.
Yeah. Well, thank you so much for spending your time with us and sharing about yourself and your practice and everything that you do. So where can everybody find you?
I'm at Dr. Jose Barrera, Dr. Jose, Jose Barrera on Instagram and Facebook. or drjosebarrera.com. We're in San Antonio, Texas. Easy to find us. But I got a couple questions for you because
Oh,
nobody
okay,
asked.
okay, great.
What's new with you?
What's what? Sorry.
What's new with you,
New?
Dr. Sturm?
Oh, there's always something new. We're looking at expanding, and I've talked to you about this, into building our own OR, and so I've gotten some contacts from you, which I really appreciate. I had a good call with your contractor last night, and so I don't know if you can see the building behind us. I don't know, the glare, not really, but that's the building that I want to go to.
Nice.
So
Nice.
yeah, I was telling them the surgical center that I normally go to completely closed as of like yesterday, and
Oh
so
no.
we're scrambling to find a place to go. And so it's the doors open where it's like, no, you have to walk through the door now. you know, you've got to build it out.
Yeah, you got to
So
build it out. Well, Angela, you're a fabulous surgeon. I have 3 ORs in San Antonio. You can come anytime. I'll
awesome. Well,
have a
thank
place for
you.
you any day of the week. You can
I
operate at our
have
clinic.
thought about it. I was like, I should ask him. Can I
Yes,
come operate?
we literally have 3 ORs open 5 days a week. So yeah, we would love to see you in San Antonio.
Amazing.
And I used to go to Houston as well
Oh
to
yeah.
see patients in my early career. So it's not far at all.
It's not a far
Especially for
drive.
someone of your talents. Your patients will follow you anywhere.
Oh, well, thank you. Yeah, no, I actually would really love to come operate in San Antonio because I've had people that are like, "Are you coming to San Antonio?" I was like, "Well, I don't know." So,
Why not?
yeah, absolutely. I would love to. We'll talk. I told Art yesterday I want to come see your facility and all the things that you're building, and that I've been planning on doing that, and I want to go over there. And the kids love the JW Marriott there, so I can dump them off at the hotel.
Yeah, there's actually, yeah. That's a great place. They would love that. And there's good barbecue right nearby. So,
Yeah, it's super fun for them, and then I can come tour the facility. So we'll make it
yeah,
happen.
and they could go to SeaWorld
Hmm.
right across the street. Yeah, you
Yeah,
should. We could do it.
yeah, we'll make it happen. Well, thank you again. Thanks for being on here. I really appreciate it.
Thank you all. It's a pleasure being with you, and we'll definitely touch base soon.